So now we'll go through these sets of real case scenarios, and we'll try to dissect each case, and we'll try to see what is the ideal way to practice a sleep medicine and what best we can do with the existing modalities that are available with us.
So the first case, a 45 years old male, office worker by occupation, he came to us with complaints of snoring and daytime sleepiness for the last 1 year with daytime fatigueness. He had a comorbidities of diabetics and hypertension. He is not a smoker nor an alcoholic, and he was not on any sleep medications.
So now, my question to Dr. Nagarjun sir, like what are the leading questions in a clinical history which you would ask whenever you suspect a patient with an obstructive sleep apnea?
So I think when we suspect a person to have OSA, the history should be not only from the patient but also from the bed partner. I think this is the most important thing, because many times the patients may refuse that they snore or they have sleepiness, but it is the people who are sleeping along with him that they give the history. So again, as far as history is concerned, I think I would classify the symptoms into symptoms related to the sleep and symptoms during the daytime. So snoring, the intensity of snoring. Then the choking spells, I think this is one of the most specific things for OSA, the number of times the person actually chokes and gets up. The partner also we have to interrogate and ask if they have witnessed apneic spells, any history of nocturia. Then when you get up, you're feeling fresh, you're not feeling fresh. Then the presence of daytime sleepiness. You can ask some leading questions also as to how sleepy the person is, whether he's actually slept while waiting for you in the waiting area. Sleeping while driving is something which I always ask, because it is very important to also advise them not to drive while we are evaluating and treating. And also fatigue. Not many people have actually sleepiness, but they may just have fatigue. So this is all the basic things which we have to cover, I think.
Yeah, and now my question to Dr. Nalini, like, is there any difference you see in the pattern of presentation between men and women when it comes to the symptoms related to sleep disorder?
Yes, I think this gender-based medicine is very much present in sleep patients also. So there are differences, and the excessive daytime sleepiness subgroup is more common, cluster phenotype is more common in men rather than in women. Women complain more of daytime fatigue or lack of energy. They complain of more headaches or increased pain sensitivity. So usually they do not complain of snoring. They don't want to come up with their symptoms. So most importantly, they go to either a rheumatologist or to a physician saying that we are not doing well, we are having low energy, or our pains are not coming down, bone pains are there, joint pains are there. So usually this is the spectrum of complaints that we see in women.
Yes. Actually, cluster analysis among the population has shown that amongst the female patient, majority are having a middle-aged women. They have a mild to moderate degree of OSA, and they have a problem of actually insomnia. They present with insomnia and daytime fatigue. They will not complain of snoring or not complaining of witnessed apneas like that, or not daytime sleepiness. And actually, there is a group of the patient having insomnia associated with OSA, that is called comorbid insomnia with OSA, and there is popularly termed as comisha. Actually, this prevalence is about 40% in the general clinics. So patients have OSA associated with insomnia, and they are very poor tolerant to the CPAP. They can't tolerate CPAP. They will not tolerate, and they will show a poor adherence to the CPAP. So particularly female, we have to think about OSA whenever they are consistently complaining of fatigue, daytime fatigue, and disturbed sleep.
So the point to be noted for all the participants at Davis here is not all of your OSA patients will smoke. In fact, if you see the data, only almost around 60 to 70% of the patients who come to you will really have, of OSA will have a snoring. So you need to probe into the history to really find out. So many of these patients can present you with a chronic fatigue syndrome, especially post-menopausal women coming to you with depression, insomnia, then probably you may have to suspect OSA if you have a greatest probability. So we'll go further on to the case.
So our patient had witnessed apneas, unrefreshing sleeps, and poor concentration. So followed by that, we went on to the examination. So the BMI was around 28 kg per meter squared, and neck circumference was 18 inches, and multiplicity classification, it was class 3. There was no dental or ENT abnormalities, and the systemic examination were all within normal limits.
So again, a question to Dr. Samina sir. How your clinical examination will really aid in evaluation and management of patient with OSC? What are things you really look for in a patient who presents to you with OSC?
So actually, we have known that obesity is the most common problem. So obesity is the more than 70% of cases usually associated with obesity. So number one is the BMI, and then ask for the see the neck circumference. If the patient has larger neck circumference, more than 17 inch case of male, or more than 16 inch female, or in centimeter, more than 43 centimeter in male, or more than 41 centimeter in female. That is much more significant than the obesity, actually more than the significant than the BMI. So body weight, BMI, neck circumference, then to look at the inside the mouth. Ask the patient to open your mouth and see what is the location. Can you see the posterior pharyngeal wall? That is what is the situation of the crowding of the teeth. And that is the, we can assess the Mallampati score, which is assessed, and the scoring of third and fourth. This grade of they have high propensity of development of OSA in that cases. So these are the general, yes? Yes.
So, Dr. Sastry sir, as an ENT perspective, is that apart from as a pulmonologist, we are doing only mainly with the Mallampati scoring. Is there anything as an ENT perspective you will focus, especially when you know that there is a high predisposition probability for OSC in clinical examination?
Exactly. Repeat it.
For a patient who comes to you with the suspected OSC, what, from an ENT perspective, is there anything else you would look into apart from doing just the Mallampati classification for in clinical examination?
See, with the ENT examination, especially I guess first thing classification is snoring or OSCA. I better sometimes many times ask for the video by the spouse. Then sometimes most of the time, sometimes patients come with the reports, polysomnography report, or they come directly to me. If they come directly to me, or there with polysomnogram based on the HA report, examination completes from nose to nasal pharynx, velum, oropharynx, base of tongue, tonsils, supraglottis, including epiglottis and vocal cords, and if possible, upper trachea. Even upper tracheal narrowing, presenting inspiratory stridor will be many times may be taken as a OSA by many people. So we have to examine from starting from the nasal LA to upper trachea. A proper, complete, flexible laryngoscopy examination and a rigid nasal endoscopy examination has to be done.
So the point to be taken for the delegates here is, whenever a patient comes, even with a high predisposition probability, you always look into their nasal cavity, because many times, as we have heard from our previous speakers, if a patient is going to have a polyp, then most probably the patient is not going to tolerate your CPAP at all. So you need to go have surgery also in the back of your mind. And along with it, you need to do the Mallampati classification, and as our panelist said, you need to look into the dental aspect of the patient also. Sometimes these patients will have a dental malocclusion, they may have a retrognathia. So all these things should also be looked into the clinical examination.
Are very important, and also do a complete examination of the patient, not just the upper airway. Sometimes we might not even auscultate a patient of suspected obstructive sleep apnea. So always look for signs of right heart failure or saturation less than 94, suggesting that this patient could also have associated obesity hypoventilation syndrome. Look for the second heart sound, any pedal edemas intermittently. They won't have gross things, but intermittent pedal edema or some exertional dyspnea and low saturations, and also some facial plethora, bounding pulse. All these things will give clinical clues in our outpatient that this patient could have a complicated obstructive sleep.
And Dr. Samina sir, what is your role of using the routine clinical questionnaires for screening for OSA? We have multiple questionnaires like Epworth, we have got the stop band, we have got the in which scenario will you?
Yes, of this there are some questionnaire. This is Berlin questionnaire or Epworth sleepiness scale, or stop bank questionnaire. Epworth sleepiness scale actually gives us an assessment of the severity of the daytime sleepiness. If the patient complaining of daytime sleepiness, then we can having a grade. And if the patient has a higher, more than 11 scores, so that is a high probability of patient having OSS. Similarly, there is a Berlin questionnaire. And most popularly, this is stop bank questionnaire. We can use it in the daily clinical practice. Stop, SOTP, stop. S means snoring, T for tiredness or daytime sleepiness, and O for witnessed obstruction during the sleep, that is choking sensation during the sleep, and P for hypertension. So these are the stop, these 4 letters, if we remember it. And this we practice in the clinical practice, we can assess. If there is more than 3 answers to these four questions, there is moderate to high probability of having OSA. And there's a bang means there are other parameters like age more than 5 in males, and male gender, and obesity. So these are the 4 another points. But stop, this 4 letter is very important for the routine clinical practice.
So in my practice, I routinely use stop bank, and Berlin questionnaire also has got very good high sensitivity and reasonable specificity. But when you give an Epworth sleepiness scale and ask the patient and decide about diagnosis, it is not a reliable test. As our previous speakers also said, it is only for assessing response to treatment rather than a screening tool. So in our clinical phenotypic clusters of obstructive sleep apnea also, about 37% only will have excessive daytime sleepiness. So rest of the people will not have, they will have either a disturbed sleep group or they might be asymptomatic. Another important thing I found is the sensitivity of Epworth sleepiness scale might be even lower in Indian population, because I am doing a study routinely, all the patients, irrespective of sleepiness, I am asking them to fill up the form. Even for people who have severe obstructive sleep apnea, the Epworth sleepiness score is not crossing 10. And in the same day, if you give 2 forms, ENT person gives 1 form and I give 1 form, there is a variability. So please do not rely excessively on the score. If that is negative, it doesn't mean that patient doesn't have obstructive sleep.
So could you mention each of these questionnaires are we used in a particular step? For example, if you are going for a pre-anesthesia evaluation, and probably your anesthetists will depend upon more of your stop and questionnaire. But if you are doing a community screening to pick for OSA in your community, that is where your Berlin questionnaire will have importance. And when it comes to the experts sleep scoring, as Dr. Nani and Dr. Samivansar have already said, it is mainly for assessing your response to treatment. Let's say if your patient with OSA, you start them on CPAP, whether the daytime fatigue has decreased or not, you will use the experts sleep score.
So in our patient, the screening questionnaires were suggestive of highly likelihood of OSA. So following by that.
So Narayan sir, like how will you further evaluate this patient? So what are the investigations will you ask in your patient who is suspected to have OSA?
So this person, I think, has a simple OSA. He has no other he has only diabetes, hypertension, but nothing to suggest complicated OSA. And the first thing is to get a good quality polysomnography. Level 1.
This is a level 1 or level 8. Now we have a patient who has got a very high pretest probability, but he is having a diabetes and a hypertension.
Yes.
So do you prefer a level 1 study or would you straight away go for a
Level 1 would be the first thing which I would suggest. Only if the person says that I don't want to come to the hospital back or I cannot, then in this case, because he has no cardiac or other comorbidities, I think probably level 3 may be an option rather than not doing the study.
So any differences from the panel, like Dr. Nalina and Dr. Samivansar?
As per guidelines, this patient can undergo home sleep test level 3. But if your lab is empty and you want to promote a level 1 lab, because you want to learn also, and you want to, why do you want to keep your lab empty when you have such an excellent infrastructure? There might be something, we never know. He might not have a moderate sleep apnea, those symptoms are high. There could be other reasons for sleepiness or positive Berlin questionnaire. Other reasons for false positivity can be there. So whenever, see that these home sleep studies have come because of the overloading on the labs. So are we all doing 30 sleep studies per month or 60 sleep studies per month in our lab? If we are not doing, we are not justified in sending for home sleep studies. We have to convince the patient about the economics, saying that doing a proper study and then a proper treatment later on will reduce the cost of repeated reviews and then follow-ups and then doing a repeat sleep studies.
Yeah. So the point to be noted is like even the guidelines says when you have a very high pretest probability, you can go for level 3, but in level 3 you will miss out on many things. Let's say the patient is having an nocturnal seizure, or let's say the patient is having a periodic leg movement, which is causing a disturbed sleep. So, or even REM-related movement disorders, many things will be missed by your level 3. So if you have an access for a level 1, then that is the best to be done. But in case if the patient is not getting a Dr. Nagarjun said, or if the facility is not available, then probably you can go for a level 3.
So this patient underwent level 1 polysomnography. So the AHI was 21.6, suggestive of a moderate severity of OSA.
So this already I think we have heard from Dr. Tripathi, like what are the parameters we have to see, so we move ahead further. Now I'd like to ask Dr. Konalakshmi ma'am, so generally you see a lot of patients who are obese and who are having OSA. So where do you really position the role of bariatric surgery, and which are the proper candidates where you front head go for a bariatric surgery without putting them on a CPAP, and how do you really convince a patient for bariatric surgery in such cases?
As per guidelines, the recent ASMBS guidelines say anyone who is above 30 BMI and having these type of comorbidities, which are lethal, they should be offered to undergo, means they would have, it meant that they have already tried various methods of weight loss and failed, or with this condition they will not be able to lose a significant amount of weight. We suggest them for bariatric surgery. And usually by the time patients come to us, they would have tried all other things and they would be fed up with the CPAPs or BiPAPs, or they are not able to use them on regular basis, which is interfering with their day-to-day life activities. And those are the patients who come to us. And anyway, when we are working up a patient for bariatric surgery, it is always a multidisciplinary approach, and they are ultimately sent to the pulmonology department to see their sleep studies and their lung condition, if there is any pulmonary artery hypertension. Then that is first managed conservatively, and they are advised to start the BiPAP machine if they are not using prior to the surgery. Get them used to the BiPAP machine for 2 to 3 weeks, get them for surgery, continue the BiPAP machine in the post-op period till significant weight loss happens and the lung condition improves, and again take the response from the treating pulmonologist whether they can go off or need to continue at a lower pressures.
So the important point of discussion is like sleep. When it comes to sleep, it is not like we own the patient. Like it's not only the domain of the pulmonologist. We need to involve our guys like ENT and bariatric surgery as well. Because we have seen patients whom we have advised to CPAP, they are taking it for some time, but the compliance, as we have heard earlier also, is going to be very less. It's just going to be 50%. So in such patients, especially those who have got a metabolic syndrome and a BMI more than 30 kilograms of meter square, then these are the patients probably you need to take a multidisciplinary consult, because reduction in the weight can bring about a reduction in the CRP of the OSA, and probably later this patient may become a candidate who is complaining on your CPAP. So in this case, where the BMI roughly falls around at 28, but patient is having comorbidities, is there any role of bariatric or any other surgeries apart from bariatric to bring about a weight reduction?
When we talk surgery for obesity is bariatric surgery only, but there are other non-surgical methods like the endobariatrics, what we call, mainly the balloon, intragastric balloon. That will be very helpful for the 25 to 30 BMI who are having these problems, where you want maybe a 10 to 15% reduction in their body weight, which would help them. Then the endogastric balloons, which are some which work for only 6 months and some which can work for a year are there. And with that, coupled with diet and lifestyle change and regular exercise, will help these lesser BMI people.
Moving on to Shastri sir, like here we have a patient who has got a moderate risk, where the AHI falls around 21, but he has got comorbidities. Is there a role of any ENT interventions? Because they say that this patient is not ready to use a CPAP, and he is having a moderate AHI, but with comorbidities. So are there any ENT modalities? What would you do next? Like, what would you offer for this patient?
See, before doing any surgery, the comorbidities have to be assessed. For your any normal surgery also, you have to take care of the comorbidities like this deep surgery. First, before doing a sleep surgery, we do a DICE. Before doing DICE, these comorbidities have to be considered first and discussed with the family, discussed with the attendants, the risk of developing apnea. If the apnea is prolonged, to the risk of doing a tracheostomy has to be addressed, first thing. Second thing, when we are operating, see, with comorbidities, with a little borderline obesity, like close to 29, the success rate may vary of the surgery. That has to be in detail explained. See, we are not going to offer a cure with surgery. This is a multimodality treatment. We are going to offer a multimodality treatment. If he is medically fit, even though if we make him fit medically before surgery and with the consent of the family members, it's a proper consent explaining all the things. There are multiple list of things to be explained before a surgery. Once you after, especially if it's a breathing on this type of collapse, especially if it's a anterior-posterior collapse, you can do an expansion palatoplasty or a papilloplasty after addressing the nose.
Dr. Adams, what would you have done in this case? Like now we have a multidisciplinary forum. We have an ENT who's saying that he can go ahead with the surgery. We have a bariatric surgery who says that we can do a balloon. So what you really do in your clinical practice when you encounter this patient who fits into the moderate dosage with a BMI of around 28? Do you offer him CPAP upfront, or you put them into a sleep board, assess all these things, and then take a decision based upon the comprehensive assessment?
So in the routine practice, what we normally do is, first thing is to screen for any obvious correctable surgical things, like what the previous speaker has said. If you have a big polyp or a big tonsil or something which is anatomically correctable other than the palatal surgeries, then obviously surgical treatment would be correct. If there is no obvious anatomical reason for OSA, then most of these patients, moderate OSA, BMI of 28, we wouldn't send for bariatric surgery. Most of them also won't go for endobariatrics, but I think the CPAP would be the thing which is what is normally advised for this sort of people. I think this is what we normally do.
What all advices would you give to a patient before you initiate this patient on CPAP? How do you gain the trust of the patient and confidence? Because that is something which we really don't know. Because in a busy practice, you write CPAP with the interface, and nobody follows up what really happens to the patient, how patients are educated, and how do you feel is the importance of educating the patient on the devices and the interfaces?
So for any device, advising any device to any patient, so education, demonstration, and keeping the confidence of the patient, it is very important. Unless the patient, we can explain his disease and what is going on, if he is not taking the proper treatment, that is the most important. So patient has a problem that is lifelong, that will progress unless it is taken care of. This is the first and foremost. And what are the problems it can develop in their daily life, how it can cripple their daily life, how it can create an emergencies or the problem with the heart, problem with the brain problems. So these are the things we should discuss with the patients about the disease, and if not treated, what are the going problems there. And then how the machine will help him. And we have to demonstrate that, and we have to abolish their fear about using a machine. As we know, whenever we are prescribing a MDI for an asthma patient, the patient is very much worried. Their parents are very much worried. So why you are giving these inhalers? So simple giving an inhaler creates so many panic to the patient, the parents. So giving a CPAP to the patient, and you have to use daily in the night, daily and all together in the life. So that creates a problem and very fear to the patient. So you have to pass out this message that it will help him sleeping in a normal situation. And if we have a normal sleep, you can have a normal daily life routine, and you can avoid the complication developing from this problem. So these are the educating the patient regarding the disease, regarding the machine, and after proper demonstration and giving trial for a few days, when the patient can get confidence, we have to ask them to buy the machines.
How do you ensure the compliance of this patient? Do you routinely get the CPAP report from them to ensure whether they are using the machine properly? And what is your take on the role of routine use of humidifiers which is being given along with the PAP machines?
So yes, compliance follow-up, as the studies have shown, the first 2 weeks are the time is the time where the patient decides whether to use the machine or not, and majority of the patients tend not to stop in the first 2 weeks. So if we can call them within a week or two and try to find out whether they're using properly or not, that is the time where we can convert these non-users into users. The studies have clearly shown that our active intervention within the first 2 weeks improves the CPAP compliance. The data card reports help a lot. We look into various adherence and AHIs, pressure requirements, leaks, and all these things, and how the patient is feeling. That is also very important. Are they pulling out their mask? Is there any claustrophobia? All these things have to be looked into. But most important is, even before you send a patient for sleep study, since most of us are doing split night studies, we have to prime the patient about PAP therapy at that time only, and tell them that you might feel a little pressure at the back of your throat. This is what we are going to do. The explanation of titration process has to be told even before the sleep study, which makes the patients relaxed, and then they will believe in the therapy also.
And what is your take on the humidifiers? Because many people use it even without patient complaint.
So the moment somebody complains of dryness, the tendency is to write a humidifier, which is not correct. Most of the times in my patient, I think not maybe one or not a single patient I have used humidifier till now, because for the Hyderabad weather I don't think we require. And whenever they complain of dryness, is it in the nose or is in the throat and mouth? Most common reason for dryness is the leak. So we have to look into all those reasons, rule out the other causes of dryness, and then only if there is a residual dryness, then we think it requiring humidification.
So the point to be noted is, when you give a CPAP, make sure you educate the patient. Because what we have observed, and most of us are since here in basic practice, you write the machine, some technician teaches them how to use the machine, and that is where actually you lose the trust of the patient. So whenever you deliver a machine to a patient, make sure you teach them how to use it. And the second thing is, humidifiers are not to be given routinely, because it can lead to increase in the risk of infection in your patient's water if the water is not changed properly. So until and whenever a patient complains of dryness, look if the patient is having a mouth breathing, or look if there is an excessive leak because of which the excessive flow is happening. And once you have ruled out all these things, then only properly you may consider a humidifier, and that shouldn't be the routine norm. And because in the interest of the time, we will be ending this case soon. So before that, I would like to know from Dr. Nani, let's say that we start this patient on CPAP. He comes back to you and he says that I am still having residual sleepiness. So patient is on CPAP, but he is not improving. What are you going to do next?
So whenever there is a residual sleepiness, first thing we have to look at is the data that the machine is going to give, because if the events are high, we look at the AHI flow. If the events are high, then we need to do something about the pressure. The pressure might not be enough. Then most important before we increase the pressure is to look at whether the patient is having any leak, and also look at the adherence. At least 75% of the days, if the CPAP is used for at least 6 hours per night, then it becomes effective. If the patient is pulling off in 2 to 3 hours, or if a REM predominant sleep apnea is there and that is causing symptoms, and if the patient pulls off by 2 o'clock, then naturally the patient is going to have residual sleepiness. So we have to look into adherence, we have to look into the leakage, and also we have to look into the residual events that are present, which can be correctable. If something is not working out by repeated trials, we have to go for a level 1 polysomnography. And before simultaneously, we also have to look for other reasons for sleepiness, like other diseases, like any obstructive, restrictive diseases, central nervous system disorders, any drugs, or sometimes the patient might be depressed or might be using, might be having a thyroid issue. All those other reasons should be ruled out. Then we do a level 1 polysomnography to see what exactly is happening. Why is this patient having residual sleepiness? In the study, are they having any central apneas, or is there any hypoventilation? We might even have to put an ETCO2 or transcutaneous monitor. And then, if no reason has been found, we might even have to go for a MSLT test, look for any narcolepsy. Association of obstructive sleep apnea with narcolepsy is very much there, in which CPAP intolerance will be there. They might not, they might have sleep disruptions in the night time and sleepiness in the daytime. So that association also has to be looked into before we label as residual sleepiness after CPAP therapy.
So whenever you have a residual sleepiness after providing a CPAP, as Dr. Nalini had already said, first always look into the compliance of the patient, whether the patient has really used it or not. Then probably, as we have discussed already, narcolepsy is a coexisting phenomenon, and in case it is that, you can write modafinil in these patients. And another important thing is always go back. Compliance will be the major issue in a given time. And moving on to the last question to Dr. Nagarjun, how commonly you see your patients being compliant on CPAP? Like you have administered CPAP in your routine practice. How much, in a rough number, how many percentage of patients really use the CPAP, and do they really come back to you with those reports?
Yes, I think this is something which we looked at our data also. I think a couple of years back we tried to look at the long-term adherence to CPAP, and it's very interesting to find that at every step of care you have around a significant chunk of them who don't come. Starting from we order sleep study, how many get a sleep study done, diagnostic. There you have around 30-40% who don't even get a sleep study because they're not even convinced that they have OSA. So this first dropout occurs when you pick up and the patient doesn't come. If the patient comes with snoring and sleepiness, he will get it done. Suppose he comes with uncontrolled asthma, refractory hypertension, you suggest, then there will be some percent of them who won't even get a sleep study done. Then the second dropout happens in the titration and starting. So even though you diagnose sleep apnea, some of them don't understand the need for the CPAP despite you counseling them. So that is another 20-30% of them. After getting a titration study done, after showing them that CPAP is helping and you suggesting them to use CPAP, how many actually initiate CPAP? Again, some percent of them don't even start to use. Here also there may be several reasons why they don't want to use CPAP, starting from financial difficulties to the patient's unwillingness to use a machine. There are many people who say, I don't want to put the machine without even trying or even trying to use for a couple of weeks. This is where the counseling is very important. Then, if a person starts using CPAP, then the adherence and continuing CPAP, again, short term and long term, both are there. As Dr. Nalini Madam has said, the initial couple of weeks response is important, but then, so that is a short term adherence and then the long term adherence. So, at the end of the day, from if you look at the number of people whom we ask for sleep study or whom we advise therapy, the percentage of people who actually have long-term adherence, I think it would be only around 30% or so. Roughly around 70% will not be properly adherent to PAP therapy. This is the ground reality.
This is something which we have to realize. So until and unless you actively look for compliance in your patient, most of your patients will not be using your CPAP. And the take-home message from this entire panel discussion is, more than we knowing the aspects of OSA and CPAP, it is for us to impart this knowledge to the patient. Until and unless we take time to educate our patient on the problem as well as the management aspect, then the compliance is going to be always an issue. So in the interest of the time, we will end the panel discussion here. And we'll just break for a short period, and after that, we will have this workshop.